All right, everyone, let's jump right in. Today, we're going to do a high-yield review of peripheral nerve blocks, and we'll be using Dr. Farhad's excellent notes as our guide. We're going to focus on the core principles and the key techniques you absolutely need to nail down for safe, effective clinical practice.
So we've broken this down into four main parts. Think of it like a grand rounds. We'll start with the fundamentals, the core principles. Then we'll take a tour of the upper and lower limbs, block by block. And we'll wrap up with trunk blocks and what is really the most important topic of all, patient safety.
Okay, let's dive into the fundamentals. Before you even think about picking up a needle, you've got to understand the huge value regional anesthesia brings to our patients. And, just as important, the essential prep work that is the foundation for every single successful block. Look, remember, we're not just numbing a body part here. We are fundamentally changing how the patient's body responds to the stress of surgery. That means fantastic pain control, needing way fewer systemic drugs like opioids, which in turn means fewer side effects. And get this, it can even mean a lower chance of developing chronic pain. It's a massive win for the patient's entire surgical journey. This right here, this is non-negotiable. I really can't stress this enough. Every single block, I don't care if it's a simple finger block or a complex plexus block, demands this exact level of preparation. This is your safety checklist, and it has to be complete before you even think about starting.
How we find nerves has changed so dramatically. We've gone from these indirect methods, like getting a twitch with a nerve stimulator, to a whole new world of direct visualization with ultrasound. Honestly, it's revolutionized our practice. We went from inferring where the nerve was to actually seeing it in real time.
And this image just perfectly shows why ultrasound is such a powerhouse. Being able to see your entire needle, the tip, the shaft, and its relationship to your target nerve is amazing. But just as important, you see the things you want to avoid, like blood vessels or the pleura. This is a total game changer for safety and success. Knowing if you're in plane or out of plane is day one stuff. Okay, let's head over to the upper extremity. We're going to focus on the big brachial plexus blocks and really highlight those anatomical pearls, the little details you absolutely have to know to be successful in your practice. So, how do you choose your block? Well, it's all about the surgical site. Just think about it like you're moving down the arm. If the surgery is on the shoulder, you're going to be up high, at the interscaling level. If it's on the hand, you're way down in the axilla, targeting the end branches. The anatomy dictates the approach. This is a massive clinical pearl. Don't ever think, oh, it might happen. You have to assume a 100% incidence of phrenic nerve palsy with an interscalene block. So what does that mean? It means you have to seriously consider your patient's lungs. Can they handle having half their diaphragm temporarily out of commission? For a patient with severe COPD, this block could be a huge problem. Now, the axillary block is super interesting, mostly because of what it misses. Because we're blocking so far down the arm, some important nerves, like the musculocutaneous, have already peeled off higher up, so you have to be ready to supplement the block, which usually means finding that musculocutaneous nerve in the coracobrachialis muscle and giving it its own little bath of local anesthetic.
And here it is. This is a classic board exam question, but more importantly, it's a real-world reason why your block might fail. The intercostobrachial nerve, which comes from T2, not the brachial plexus, is the culprit when your patient complains about tourniquet pain on their inner arm. You've got to remember to do a separate subcutaneous wheel of local in the axilla to catch this guy.
All right, let's shift gears and head down to the lower limb. The anatomy here is totally different, right? We're dealing with both the lumbar and the sacral plexuses. Our big focus here is going to be on finding that sweet spot between great pain control and letting the patient move around. Think of this slide as your roadmap. You can't block a nerve effectively if you don't know where it goes. Understanding this sensory distribution, knowing which nerve covers which part of the foot, is absolutely fundamental to planning a successful block for any foot or ankle surgery. So when it comes to the knee, this slide shows the big clinical trade-off we have to make. For a long time, the femoral block was king, but it knocks out the quadriceps, which is a major fall risk. That's why the adductor canal block has become so popular. It mainly gets the saphenous nerve for sensation, but it largely spares the quad muscle. That means great pain relief, and the patient can get up and walk sooner. It's a huge win. Okay, pop quiz. To get a complete solid block of the foot, what's that magic number? How many nerves do you have to anesthetize? Yep, the answer is 5.
You've got the saphenous, the deep and superficial peroneal nerves, the posterior tibial, and the soral nerve. For a truly comprehensive ankle block, you have to systematically go after all 5 of these nerves. Miss one, and your patient will let you know.
Now, for bigger surgeries on the lower leg, the sciatic block is our workhorse. This image shows the classic landmarks for the Labbit approach. You draw that line between the posterior superior iliac spine, the PSIS, and the greater trochanter. This is a foundational technique that every anesthesiologist should know. All right, let's move into our final section. We'll talk about a couple key truncal blocks, but then we're going to circle right back to the theme that has to guide everything we do in regional anesthesia: patient safety. This fact right here, you need to burn this into your brain. The space between the ribs is loaded with blood vessels. That means any local anesthetic you inject there gets sucked into the bloodstream super fast. You can hit toxic levels much quicker and with less drug compared to other blocks. You absolutely have to be careful with your dosing. This table basically summarizes some of our worst case scenarios. And you'll notice the big risks are different for different blocks, right? With a supraclavicular block, you're worried about a pneumothorax. With an intercostal, the big fear is local anesthetic systemic toxicity, or LAST. But look at that prevention column. What's the common theme? Meticulous technique, and more often than not, ultrasound guidance. These are your universal rules. This is your safety net, and it applies to every single patient, every single block, every single time. No exceptions. This isn't just a list of suggestions. This is how you protect your patients from harm. Full stop. So I'm going to leave you with this question to think about. Look, mastering the hand-eye coordination to do these blocks just takes practice, but cultivating a deep, reflexive culture of safety in everything you do, now that is what truly separates a good anesthesiologist from a great one. And that's the standard we should all be shooting for.